Hey folks, welcome back to the Medics, Musing, and Mayhem podcast. I wanted to start off today by thanking everyone so much for the feedback we've gotten so far. When I started this project, I wasn't entirely sure what to expect or what the response would be. As I'd said in the intro, my main goal was to create a podcast that was designed for my paramedics and EMTs so that we could better provide education to them in a clear and concise manner, which would allow for a better and more in-depth conversation during our meetings. However, while we've been making this podcast, I have discovered that we are getting a resounding amount of feedback from the EMS community as a whole. I have received messages of encouragement as well as suggestions about other podcasts in the future. And so I just wanted to take this moment to thank you all so much for your support. And I hope you'll continue to get the word out about this podcast as we continue to grow it more in the future. I also wanted to give a brief disclaimer about the upcoming podcast, as we did have some technical difficulties while creating your content this month. Thankfully, I did get in contact with a fellow EMS as well as podcast enthusiast by the name of Phil Aguet, who was super helpful and very gracious as to help us try to limit the amount of issues with the sound as much as possible. So while you're listening today, you will note that Regan's sound is actually quite good, but for some reason, one of the settings during our recording caused some mic issues on my end. So if there are parts that are unintelligible or not entirely clear, I apologize. But given how well the podcast had flowed that day, we opted to proceed with the current content. So I hope you'll sit back and enjoy the following discussion on congestive heart failure.
Hello, everybody. Welcome back to our third installment already of Medics, Musings, and Mayhem. Feedback we've gotten has been great. We're actually closing in on our 200th listener already, so I guess there's a lot of interest and passion for rural EMS out there, and not only in Minnesota and South Dakota proper, but I've heard from folks in Chicago, and there's actually been some international listeners as well, so crazy just how much interest has been developed already.
It just makes us more and more excited to make these episodes.
Not only make them, but make them better. So hopefully we can keep the momentum going. And as always, we welcome any feedback from our audience and from our folks that have any ideas for future talks. And there was actually some suggestions about getting some guest speakers on here at some point, which is certainly a cool idea, but we can definitely play with that more once we get further down the road. Today, I decided we'd switch it up a little bit, though. We had really unpacked bradycardia ad nauseum the other day, and instead of barraging people with an additional set of really complicated cardiac circuitry, I figured we'd take a step back today and talk a little bit more about heart failure. I feel like that's a little bit more straightforward, a little less complexity when we think about the heart itself versus the circuitry we talked about before. Thankfully, I've got my good friend Regan back again to help me out with this. Hello, Regan. Thanks for helping us out.
Thanks for having me back.
Well, I mean, you're doing a lot of good stuff, and clearly you've got a passion for this, and we're just glad to have someone else to share their thoughts and to talk through some of these scenarios, especially since you have your EMS background as well.
Absolutely. It's really fun to pull from that, having been out of the field for a couple years to be in medical school. So it's enjoyable to bridge these two together.
For those who are deciding to jump right into heart failure and miss the first couple episodes, the way these podcasts are set up is that we talk about a scenario to open the discussion. We talk a little bit about pathophysiology. We move on to the ways that we can treat the pathophysiology and how these medications work specifically. I like to take a look at some of the evidence-based medicine out there for the relevant discussion point as well. And then lastly, we tie it back in by talking about the protocols that we're designing for our rural shops right now, as we're kind of in a phase of transitioning and trying to make sure all our protocols are up to snuff. And once we finish the protocol, we go back to the case and talk through that. With no further ado, why don't we start with our new scenario?
Sounds good to me.
All right, you're back with the EMS cap again here. You get a page, you hear that there is a 65-year-old woman calling with concerns of feeling really short of breath. Top of the ambulance, you get over there, you notice this woman is very winded upon opening the door. She's just very dyspneic, able to get maybe a few words out at a time. She's also tachypnic. What she is able to tell you very briefly is that she just got back from a very big Thanksgiving dinner with her family and that her legs feel puffy. What do you want to do with that information?
Well, my mind is running through a few things that could be going on. But of course, the first things we want to do is keep asking some questions while we get those vital signs.
Yes, vitals, vitals, vitals. So we will walk through your vital signs first. So while you're obtaining the history, your partner is getting them hooked up. They start giving you some of the numbers. First of all, the blood pressure is 220 over 90. Heart rate is about 110 or so. Her respiratory rate is in the 30s, and her O2 saturations at this moment are 83%.
All right, so I don't like a single one of those vitals. They're kind of all over. An elevated blood pressure, of course. We have that fast heart rate. We're breathing fast, but we knew that from when we were looking at her. And our SpO2 is going down. So overall, we kind of need to start getting some actions taken.
Yes, totally agree. The first thing you want to do, as we've talked about before, is you want to get that rapid assessment. When I talk about that, what I'm saying is we're looking for ABCDEs. That's the thing that we got taught a lot in ATLS before they switched over to some of the newer mnemonics. Ultimately, we want to assess her airway. And as we talked about earlier, she's able to get a few words out at a time, but that's about it. When you take a listen to her lungs, you hear some crackling at the bases. Pulse-wise, she's tachycardic but regular. Her disability, or GCS, is 15. Looking at her, because we talk about like exposure, we're not going to undress her necessarily, but we want to observe what the patient is doing. And she definitely looks uncomfortable as she's sitting there breathing really quickly. Any additional information you would want to know?
I'd want to ask about her medical conditions and any medications that she takes. Those can usually help paint the picture of what is going on, even if it is an acute scenario.
My heart doesn't really work the best. The doc has me on a bunch of medications. I don't really remember the names. My son helps set up the pill box every week, and I just take them.
And that's not an unusual story that we hear in the field. So, this is where, if we have a second, I can have one of the family members go grab the medications, which can help us to just start looking at the pill bottles and continue to ask any more questions that she might have the answers to, or a family member may as well.
I would imagine hopefully you'd have some collateral available, especially with someone who has these vital signs. Keep in mind they're probably going to be breathing really hard, barely able to get much out, and it might take you a really long time to get a good history if you were talking to the patient only. So definitely ask for collateral, and push comes to shove, then we just try to get the patient stable first. So with that presentation, and since we already talked about the fact that this podcast was going to be focused on heart failure, let's take a little step towards the pathophysiology component. And since Regan is much closer to medical school than I am, why don't you start by briefly summarizing in very general terms, what does heart failure mean? Like, what does that look like over a series of time?
Yeah, so heart failure, fairly straightforward. Our heart is failing to do what it needs to do. It's not being able to get blood circulated through properly. And this isn't something that happens overnight. Throughout our life and throughout things that we do with our bodies, we can actually put some stress and wear and tear on the heart. So slowly we might start losing some contractility, or the ability for the heart to actually squeeze that blood, which can lead more to a systolic failure. Or we can have some damage go to our heart, which makes it unable to fill with blood properly, leading to that diastolic failure. But all in all, the point of heart failure is that we aren't actually able to get that blood around where it needs to go.
Another important thing I think I never really thought about until I brought up in med school is systolic and diastolic are not limited to the left and right ventricles. I had this faulty assumption as a student. Diastolic was a right-sided heart issue and systolic was a left-sided heart issue. And that's not the case at all here. When we think about heart failure from a bigger picture, like Reagan said, there's going to be some progressive damage that's sustained, and that can be due to a variety of reasons. This could be due to uncontrolled blood pressure for prolonged periods of time. Maybe this person had a heart attack. Maybe they're a smoker. Maybe they have a history of really bad lung disease. All these things over time can contribute to slow damage and what we call remodeling of the heart tissue. And when the heart remodels, this leads to some shapes and sizes that are not necessarily conducive to effective blood pumping. As that progresses, then the heart continues to change its shape further and further until, unfortunately, a patient might get that final push into an acute heart failure exacerbation.
The important thing with the remodeling is that it's not actually the muscle that's being remodeled back. So anytime that there's that damage occurring, you're not actually getting that function back completely. You're going to have deficits with each round. And that's why all these factors can cause a lead up to heart failure, since that structure can't actually fix to its original self.
Once this tissue is gone, it's gone for good, and the heart does its best to compensate, but at the same time, it's just not working with the same material it had at birth. Now, there's a lot of ways that we could classify heart failure and its presentations. As you know, I'm a big believer in the KISS approach, keep it simple, stupid. When we think about this from a pre-hospital setting, there's three types of scenarios that I want people to think about. We have what's called acute decompensated heart failure. We've got this new term that I've heard recently called SCAPE, which just means sympathetic crashing acute pulmonary edema. And then we've got the scariest of them all, cardiogenic shock. Going from relatively controllable to poop our pants on the spectrum, we start with acute decompensated heart failure. We talked about a lot of this already. The bottom line here is that over time, the heart is sustaining chronic damage and stress, which leads to this imperfection of structure because we've lost a lot of that vital tissue that was once helping the heart function at 100%. There are various changes that can happen. The heart can get hypertrophied, meaning that the muscle gets a lot bigger. It can also dilate and also start to thin out. Sometimes it's a little bit of both. Going back to our discussions about arrhythmias several podcasts ago, we talked about how when the structure starts to change, the circuitry can get affected as well. So keep in mind, as the heart stretches or thins, the wiring can get messed up as well and lead to future arrhythmias in certain situations. So over time with these stressors, the walls become less compliant, which means that when the blood flows into the heart, it's not as able to expand. It's also much more stiff, meaning that the heart can't quite contract as effectively, which leads to worsening of ejection fraction. A lot of times when we talk about patients with heart failure, they've had a lot of echocardiograms done, and they talk about ejection fraction. That's where this whole thought process comes from. The other thing is not only do we worry about how much blood is getting pumped out, but also how much blood is left over after the fact. And so one of the other issues that comes up is that we have issue with filling over time. So sometimes we just can't fill the heart completely to what we used to, and then we can't pump it out as much. Impaired filling can develop either there's a bunch of blood that goes in and not much gets pumped out, or there's so little compliance left that not much blood can get into that area during different phases, and that way only a certain amount gets pumped out as well. Basically, what we've painted for you now, the heart is already kind of in a tenuous situation when it's got this history of heart failure, this history of remodeling happening. So you can only imagine that when we introduce stressors into a patient situation, this is going to lead to some instability to the heart. As we get these stressors, such as stress, electrolyte disturbances, fluid overload, patients not being adherent with their medication regimens, this is what starts to lead to instability in hemodynamics for the patient. And as the patient starts to go through these changes in the heart, for example, the heart's not able to pump blood out, the blood pressure either gets really low or gets really high, and then we get what we call a sympathetic event. Your heart goes into fight or flight mode and starts pumping in all these catecholamines, which is trying to get the heart to work harder, which will ultimately wear it out, which leads us into one of the more severe subtypes. And this is where the sympathetic crashing acute pulmonary edema comes into play. This traditionally happens in the context of minutes to hours. So when we think about it, when a patient is going through what we already described with decompensated heart failure, you've got decreased perfusion because the heart's not able to eject as much blood as we would like. And you've also got poor oxygenation, mainly for two reasons. One, because you're not getting as much blood as you want out as possible, so you're not getting as much oxygen out to the system as you'd like. Secondly, depending on the type of heart failure, you might have some backflow into the lungs, which then messes with the lungs' ability to effectively ventilate and oxygenate. As a result, we start to see this increased afterload, which means that after the heart is pumped, there's fluid left over. That leftover fluid can then backflow into the lungs. And the consequence of this increased afterload and backflow is what happens when our patients then start to describe this chest pain and feeling really short of breath, or this feeling like they just can't get a good breath of air, or when they walk, they just get really wiped out really quickly. And as a result, we get more of this sympathetic surge. After our body has burned through all these catecholamines, all this adrenaline, we start to decompensate. The body's used up everything it can, and we're at a place where the heart really has nothing left to give. The other thing to keep in mind with these patients is clinically, they tend to be fluid depleted. And that doesn't necessarily mean that they've lost this fluid out of their body. It's just that the fluid is in the wrong place. So for patients with heart failure, we think about fluid to the lungs is very common, fluid to the legs. Patients that have 2+, 3+, 4+ pitting edema, this is where all this fluid goes off. And that's why the patient is a little bit hypovolemic in this scenario. Now we move on to the scariest one that makes everybody really nervous, whether you're a paramedic, an emergency medicine physician, or a critical care doc. Cardiogenic shock is the worst scenario. We talked about escape and that we're starting to get to that point where we're starting to lose all of our sympathetic surge and we're starting to decompensate. This is the point where the decompensation is happening and the patient is effectively going into shock. When the heart is at death's door, so to speak, the blood flow going out is very low. Due to the decreased flow going out, you don't have great pressure either, so the patient gets very hypotensive. With cardiogenic shock, though, we want to make sure that we keep in mind cardiogenic shock can be an acute situation. The patient could be having a serious MI where they're losing a ton of tissue suddenly and the heart's no longer able to pump effectively. That's one way that the patient can get into cardiogenic shock. This can be more of an acute on chronic situation in the case of like an acute decompensated heart failure. This can happen in the escape scenario like we talked about above. And lastly, there's the patient that's been putting this off too long. A good example would be the COVID pandemic. We had a lot of patients who were afraid of the virus initially, who would stay home, and their heart failure would get worse and worse and worse. And then they'd call the ambulance once they came in decompensated heart failure or in cardiogenic shock. Cardiogenic shock is one of those situations where the heart has used up basically all of its resources, and this is primarily due to either the effect of the patient having some form of systolic dysfunction, some form of diastolic dysfunction, or worst case scenario, patients that have both of those things. And once this heart is finally given out or it's lost all that reserve, severe hypotension develops, which then is going to lead to a lot of downstream effects. When we think about really bad things with cardiogenic shock, what do you think about clinically with the patient? What sort of signs and symptoms can you see on an exam?
We're thinking of things like end organ failure. So anything that is causing like an altered mental status, we know that effects are going to the brain. Or if we're no longer making any urine, we know that our kidneys are starting to fail. Effects like that where you know that it's not just the heart that's having problems now, it's the rest of the body.
Cap refill would be another good thing we could do in the field. So if a patient has very, very poor cap refill, 8 seconds, 10 seconds, those should be your warning signs that perfusion is in the danger zone for sure. I think I've adequately scared everybody now for all the badness that is heart failure. Let's talk a little bit about how we can go about treating these things. What is one of the frontline medications that we think about after describing a little bit of the pathophys here? Like, what is our first line for a patient that we think is in early heart failure or more of like maybe escape?
So the first one we're thinking of is going to be nitroglycerin. And on the ambulance, that's typically with our sublingual routes, which absolutely works in this case. I think a lot of us EMS people are very used to nitroglycerin being for like an acute coronary syndrome or other types of chest pain. But in this case, you can use this for heart failure because it helps with that preload and afterload, as we've mentioned previously, and can reduce the work that the heart is trying to do, help relax some of that pressure on it so that it's not overworking and leading us into a more serious situation like cardiogenic shock.
And we're pathophys nerds, so how does nitroglycerin work? Give our friends a bird's eye view of what's going on behind the scenes to help promote this change for our patients that are in really bad heart failure.
Well, trying to keep it as simple as I can, the nitroglycerin is actually going to increase a release of nitric oxide. Makes sense based on its name with nitro in there. But this is going to happen in the vascular smooth muscle cells. So when there's more nitric oxide within smooth muscle cells will actually relax, causing dilation of the vasculature, like the veins and arteries. And that dilation allows that blood to actually be filled in the veins as opposed to being crammed within the heart. So again, it's taking some of that pressure off the heart by bringing the blood back into that vasculature.
The main purpose of nitro in the context of heart failure is that we really want to cause venodilation. We want the veins to dilate as much as we can because we already talked about some places the fluid likes to hide. Mainly in the context of the really sick CHFers, it's going to accumulate in the lungs. So by creating this dilation behind the lungs, we're allowing the blood to pool further downstream, hopefully allowing the heart to get a little less stress. By getting that fluid further downstream, we effectively are reducing preload. And these are the terms that med students dread. Preload basically means where the heart is at before it pumps. So by effectively reducing the amount of volume in the heart, you're reducing the amount of work and the amount of strain the heart has to do to get that blood out. Another nice part of that is as the heart is able to pump some of that blood out, we're also decreasing the afterload. afterload is basically the pressure post-contraction. So when we think about this, when the patient is pretty much fluid overloaded everywhere and the heart is really struggling, the more resistance downstream, the harder it is for it to get that blood out. But by causing this vasodilation, by taking some of this fluid strain off the heart, as we start getting the heart to pump at that level, it's going to facilitate a much more organized pump. It's going to provide less strain on the heart. It's going to require less myocardial oxygen demand as a result. There's some element where we have a little bit of coronary dilation as well, but that's more in the context of like an ACS scenario. When we think about that, though, before we give this medication, Regan, what is the one question we should always ask a patient, especially if they're male?
We should be asking every male patient if they are on any erectile dysfunction medications, especially the phosphodiesterase 5 inhibitors. So these would be things like sildenafil. And this is because we can have a plummet of blood pressure if we have both a nitroglycerin and these ED medications on board.
I should include that this is not necessarily just seen in men. There are some situations for female patients where these phosphodiesterase 5 inhibitors are used for blood pressure management in elderly women. So you want to still review people's med list, but the most common person to think about in this case are older men that may require this medication. So you give these medications, Regan, how long do they last and how quickly do they set in?
So they can last up to 15 to 30 minutes, and they'll set in actually within minutes, usually 2 to 5. And the effect is pretty quick, which helps us because we can continue to give nitroglycerin every 3 to 5 minutes. Nitroglycerin has a very quick onset of action, usually just 2 to 5 minutes. So we can see that drop in blood pressure usually fairly quickly to help assess when we have these next doses coming up, which can be added on in 3 to 5 minutes.
And this is the quick and easy approach when it comes to the pre-hospital setting. So when our EMTs or paramedics are providing this, this is a quick fix to help address the fluid overload issue in a pinch. There are things like nitroglycerin drips that are a possibility, but in the context of rural EMS, a lot of the time you're going to get to the facility before you could even get a drip going. These drips can be expensive as well, and for some of these smaller services, it's probably not within their scope of practice. It is also very likely that for those of you that bring these patients in, they're also going to likely need transfer out. So we want to definitely keep in mind that there are nitroglycerin drips out there that you can then use going forward to continue to facilitate a more prolonged venodilation for that patient to help keep them more stable in transport to a higher level of care. So nitroglycerin is the big one, but what other medications do we have in our arsenal that can help address fluid overload?
So another one that we have is furosemide, which is a loop diuretic. And now typically this isn't going to be a very acute fix. Unlike that nitroglycerin, this can usually take a little bit longer to see some actions. However, it's still helpful to get these on board earlier. So loop diuretics, they're going to work within the kidney. Within that kidney, there's this functional unit, and we don't need to get into the specifics of it, but there's a section called the loop of Henle, and that's where loop diuretics work. Makes sense. So within that loop, these diuretics are going to block a co-transporter that's moving around sodium, potassium, and chloride. And stopping this co-transporter is going to cause higher ion concentration within the loop, which will also pull water into the loop and thus into the urine. So really what these diuretics are doing is taking that water, that extra water that we have in these patients, and trying to get it out of the body through the urine.
This is one of those drawings in med school that cause nightmares for all of us. But the way to think about these two is these loop diuretics allow electrolytes to go into the fluid to help pull water out of our system, right? Like the goal here is that we always talk about from high to low. So in the context of like the loop of Henle, what comes out is that the sodium is getting pulled into these tubes, which as a result, areas of high concentration of sodium are going to pull that water from our body into this tube so we can start to excrete it. Even though furosemide is not going to be the quick fix, by getting that medication on board once we have an IV in place is going to help start that facilitation of getting fluid out of the patient's body. And you can be absolutely sure that by the time they get to a higher level of care, they're probably going to get a Foley catheter and additional Lasix anyways. We've talked about more of the acute on chronic exacerbation of heart failure. We've talked more of when a patient starts trending towards that scape, the sympathetic crashing acute pulmonary edema. But let's just take a second again and think about how we might manage a patient in cardiogenic shock. So this is a much more nuanced scenario, right? When we talk about cardiogenic shock, we've got a patient that's blood pressure is already shot. So when we think about giving nitroglycerin in this scenario, that's not really a valid option anymore because we don't want to drop the patient's pressure any further. So just to, again, briefly reiterate what cardiogenic shock looks like, keep in mind that at this point, the heart is taxed. It's completely dysfunctional. The diastolic, systolic, or both components of failure have led to this drop in cardiac output and drop in blood pressure. The body no longer has the capabilities to do what is necessary to keep those things up. What is going on prior to this drop is that we've got this surge in catecholamines. Like I said earlier, the body's going to go through this adrenaline surge where we're going to get a bunch of catecholamines into the system, which are going to promote vasoconstriction, just trying to clamp everything down. But as a consequence, we're going to increase the myocardial oxygen demand because it's working harder. We've also got the renin-angiotensin-aldosterone system, or the ROS system, which is just another complex system that helps facilitate vasoconstriction, which is part of the problem when we think about using Lasix later, is that by having this ROS system, it helps to retain sodium so it can try to pull as much water in as it can, because we want to try to shunt any blood to the vital organs. Primarily in a context of shock, we want to get brain, we want to get to the heart and to the lungs. Those are like the big three that the body tries to preserve as long as possible. But ultimately, everything is going to run out of steam, and we're going to get insufficient perfusion of the peripheral organs. That's a lot of nastiness happening all at once. Step by step here, what are the medications that we can think about using, and how does that really help counter what's going on with cardiogenic shock?
So the medications that we're thinking about here are ones that are going to actually increase the work of the heart. So unlike the earlier phases of that heart failure we talked about, where we're still having that function, right now we're not really having it at all. We're not keeping that blood pressure up. That cardiac output is down. So we need to fix those two first to make sure that we can have perfusion to our vital organs. So these medications are things like epinephrine, norepinephrine, and dobutamine. All of those are going to help to either increase contractility of the heart, which can help increase heart rate, increase that blood flow around, and make sure that we still have a functioning heart and this doesn't turn into a cardiac arrest scenario.
Epinephrine is one of our best shots in this case. This is kind of what I would consider the first line, because not only are we able to address blood pressure, but we're able to hit heart rate and cardiac output all together. So we're basically addressing three things at once. So this is really the first line just because it covers all those bases. When we go to norepinephrine, also known as Levophed, this one is primarily an alpha 1 agonist with a little bit of alpha 2 and a little bit of beta 1. The main thing I want you to take away from this is that this is more so going to be a vasoconstrictive medication. So we're going to increase our blood pressure through vasoconstriction. The main takeaway with Levophed is that this is primarily intended to help with vasoconstriction. So this is more of a one-trick pony. It's going to help clamp down the blood vessels again after they've been tapped out. But this is why this medication is not necessarily a first-line medication, because if we went with norepinephrine first in the context of a really nasty cardiogenic shock, all of a sudden the heart is trying to pump all the harder, trying to get blood flow through very constricted vessels. In the event that we're given epinephrine and it seems to be helping someone, but the blood pressure just isn't quite responding yet, norepinephrine or Levophed is a good second line to further help try to get a little bit more constriction so we can try to ensure better blood flow to the rest of the body. Last but not least, there's the medication known as dobutamine. This is a bit of a cardiologist medication, but we obviously want to keep this one in mind as well. What does dobutamine do, and why is this a medication that we think about in the context of heart failure?
So dobutamine is working on beta 1 specifically. It will work on beta 2 a little as well as the alpha, but the important receptor that it's working on is a beta 1, which is mainly found in our heart. So it has similar effects as the epinephrine would by increasing that contractility, that heart rate, and that cardiac output, but it doesn't have as much of an effect on the blood pressure.
Key takeaways here. We've got three medications from a pre-hospital setting that we'd think about in the context of cardiogenic shock. Epinephrine is going to cover all your things. This is why it's first line. It's going to cover the heart. It's going to cover the blood vessels. Your second medication is norepinephrine, which is more of a focus on the blood vessels themselves and promotes vasoconstriction, where dobutamine is kind of more of a target on the heart itself. Altogether, these are great medications that really help facilitate trying to overcome this cardiogenic shock. This is why I really like to walk through this, though, because I really want my paramedics and my EMTs to really understand the thought process on why we choose these medications, so that in the event that you come up to a patient that's in cardiogenic shock, it's going to make sense to you as you give the epinephrine what to look for. You should be seeing an increase in cardiac output. You should be seeing an increase in heart rate. You should be seeing an increase in blood pressure. If you're seeing some improvement but not quite there, you move on to the norepinephrine, trying to get that blood pressure up. And if worst case scenario, you've got to think about dobutamine, or you're getting a transfer from your main facility to a higher level of care, you understand what the dobutamine is for in this scenario. Those are the main medications, but there's one other intervention that's available to us when we think about a patient that's currently in a CHF exacerbation or in more of a SCAPE or flash pulmonary edema situation. And that's BiPAP. Now, some of these smaller facilities, our rural EMS crews, this is not something that's readily available to us. We actually do have machines that are capable of BiPAP. And so I really want to focus on this momentarily, just because BiPAP is actually a major player when you think about a pulmonary edema, heart failure situation. And there's really two facets to how BiPAP works. And I'm going to try to keep this as simple as I can, but it really will help understand more why we really push BiPAP in the context of heart failure. One of the avenues that BiPAP can help with, or CPAP for that matter. So CPAP is going to be a continuous positive pressure, whereas BiPAP is a
Bi-level
positive pressure. So the way to think about this is that with CPAP, you think of your dog sticking their head out the window on a summer day. It's just a constant flow of air all the time. There's really no change. BiPAP, you actually have two settings, so that you've got one pressure with inhalation and one pressure with exhalation. So that's the way to think about CPAP versus BiPAP. Now, the main avenues for these, the main one that is most important in the context of heart failure is that this is going to affect hemodynamics. And there's a couple nuances to this. Some of this is theoretical, but when we've talked about the pathophysiology so far, it's going to make a lot more sense. The important thing to keep in mind is that patients that have heart failure are going to be much more sensitive to decreased afterload. Basically, when you hear the term that they're afterload dependent, that's just telling you, depending on how much fluid is left over in the heart, is going to dictate how effective it's going to be. So keep in mind, we talked about the context of a patient that's got horrible heart failure. You've got all this fluid accumulating in the heart, which is causing distension. You've got all this fluid in the lungs, which is causing shortness of breath and other problems. And so what this can effectively do is, once you get BiPAP or CPAP on, the pressure from the BiPAP or CPAP is going to help diminish some of that systemic venous return. So very similar to the nitroglycerin, but a different mechanism. And this is because we've got increased intrathoracic pressure. So by reducing the amount of venous return with each heartbeat, we reduce that right ventricular preload. So there's less fluid overloading that right ventricle with each contraction. What it also tends to do is help assist with pulmonary vascular resistance. This is a much more theoretical and much more complex concept, so I'm not going to get into it too much. But the idea is that by having BiPAP or CPAP and with this increased pulmonary resistance, what we effectively do is further reduce the amount of fluid that's going forward from the right ventricle into the pulmonary system into the left atria. This will all make sense in a minute, I promise. After we've talked about the right side of the heart, we got to think a little bit about the left side too. Because of the fact that we've effectively got fluid back further downstream away from the heart and out of the lungs, and the amount of fluid that's going out of the right ventricle into the lungs and then back into the left atria is being reduced, we're effectively reducing that strain on the heart. So again, with each pump, we're effectively reducing the afterload. Patients are very afterload dependent. So as long as we've gotten some of that fluid out of that system, we're basically going to allow the patient to start getting a more consistent contraction that's going to be more effective for them. With all the variables we just talked about, positive pressure therapy is going to cause a net increase in cardiac output by decreasing right ventricular preload, left ventricular preload, as well as afterload. So we've talked about hemodynamics. The other thing that it can affect is respiration. And this is a more indirect process. And this is more thinking in the context of, once the patient has a really severe exacerbation going on, we get some degree of backflow into the lungs. And so our alveoli are either flooded with fluid or they're getting collapsed because there's just too much issues going on with all that fluid sitting there. With BiPAP, and we talk about this with like COPD and asthma as well, what this basically does is it allows us to increase the pressure in the alveoli and snaps them back open and prevents them from collapsing. By doing this, we're effectively allowing more opportunities of oxygen to diffuse down into these alveoli and interact with the blood vessels and get more oxygen into our system. Keep in mind that everything that's going on during an acute heart failure exacerbation is a highly metabolically active process. The body is consuming as much energy and oxygen as possible trying to stay alive. By effectively stenting open these alveoli, we are further facilitating more supplies for the body to continue to function. The other thing that we can do, and this is what patients will talk about a lot when we think about the context of a asthmatic or a COPDer, is that by having BiPAP on, you help to reduce the stress of their respiratory muscles because it's doing a lot of the work for the patient. So by taking that stress off the respiratory muscles, you're helping them conserve energy, and it also prevents them from going into respiratory distress. And this is true of COPD, asthma, as well as CHF. So this is why BiPAP can be super helpful in that context. There's also some discussion about how it can help prevent upper airway narrowing and collapse. People that have obstructive sleep apnea, this has a lot of overlap with CHFers, and so there's a belief that this helps stent the upper airway as well and further facilitates oxygen. The other thing, again, which is more theoretical, is in the process of patients becoming increasingly hypoxic, one of the reactions in the lung vasculature is that the vessels start to vasoconstrict in an attempt to try to get more oxygen into that area. But BiPAP is believed to help reverse that process a little bit. And it's a little bit counterintuitive, but this basically allows the body to reset itself and get more oxygen into that area. BiPAP is very helpful. It's mainly going to help play a role in hemodynamics. But in terms of patients that are crashing CHFers, we always know there's an airway component to this. BiPAP is one of those ways that we can potentially avoid intubating the patient. For people that are asking, okay, that's great. We've got a patient that's crashing. What am I going to do with this? Or how do I set the BiPAP? Generally, the rule of thumb is that you're going to set your PEEP, your positive and expiratory pressure, around 6 to 8 for starting points. And then you can rapidly titrate up from 10 to 15. When we're thinking about BiPAP at my shop, we have these devices available, but generally we think about it more when we're going to transfer a patient. But if we've got the capabilities and we have the machine with us, I would really highly recommend that we consider getting this set up for patients, especially if we were concerned for heart failure, because the patients that have had CHF exacerbations or COPD exacerbations are going to know that mask and they're going to reach for it and they're going to ask for it. And it's just going to help reduce a lot of their stress because it's going to help them breathe a little bit. It's going to stent their airway open, and it's also going to help with their hemodynamics. So I really just want to hit home that BiPAP is a really key player when it comes to heart failure. We've talked about the pathophysiology of heart failure. We've talked about how to treat it, how to manage it, what other options are out there like BiPAP. And now we get to move on to one of my favorite areas, is talking a little bit about evidence-based medicine. I tasked Regan with looking into what is out there in terms of literature in pre-hospital medicine and CHF. Regan, what did you find?
So within the literature, I focused mostly on using point-of-care ultrasound in pre-hospital settings.
Woo! Ultrasound! It's my favorite. I love it. My paramedics know it. My hospital people know it. It's a great... POCUS is the best. I just can't say it enough.
POCUS is pretty cool. It's definitely a rising thing in medicine, and a lot of us med students are actually told now that our ultrasound probes are going to replace our stethoscopes in our most handy tools. So we're all just very excited to see this part of medicine grow. Hence why I looked at it for our evidence-based medicine corner. So I found 2 different studies that I want to talk about because they're from 2 different ends of the research pyramid. Another thing that we mentioned on a previous episode. But to summarize again, I've grabbed one from the bottom of the pyramid where we don't usually make changes to our medical practice, but we continue to build the research on top of it. And that's case series. These are looking at patient cases, seeing what the results were from that to help guide where next rounds of research are going. The case series that I found was from a campus that had over 200 calls within 1 year that all pertained to shortness of breath. And as a lot of us EMS crew know, there's a lot that can go on that can cause shortness of breath. So it can be hard to figure out what's actually happening with our patients. Enter POCUS, which can help us figure out what's actually happening. Within these cases, the paramedics were trained to use the point-of-care ultrasound to look for either A lines or B lines within the lungs. And to put that simply, Dr. Collins, you are absolutely welcome to expand on it. But the A lines are going to be a horizontal artifact that's going to indicate a normal lung, whereas a B line is actually going to be a vertical line that's going to indicate that there is some fluid building up within there. If you want to give a fancier explanation, go right ahead.
No, I think that's a very good summary. But another way to think about it is A-lines, like you said, are horizontal artifacts. So basically what this is saying is that if we put a probe on a patient's chest and we're looking at their lungs, you're going to see multiple horizontal lines going down on the screen. And everything after that first horizontal line is all artifact. keep it simple, it's just more so the physics of the probe causes this artifact to happen. So A lines are a common physiologic finding when you're doing an ultrasound. The B lines, like you talked about, is going to be our pathophysiology. These are the abnormal findings. So B lines, I also like to think of them as searchlights. If this is a patient that's got horrible CHF, you're going to see a bunch of searchlights all over the place projecting down into the patient's chest cavity. For the sake of simplicity, that's the main thing when we think about it in the context of heart failure.
So this case series was just seeing if those paramedics can see that A line or B line within these shortness of breath patients. So if you were seeing those B lines, that's indicating that there's pulmonary edema and this is likely a congestive heart failure exacerbation. But now as we move to the other side of the research pyramid, kind of towards the top, we have systematic reviews, which are taking multiple different studies, analyzing all of those results together to come up with a nice cohesive, this is how it is. Within this systematic review, they had 3 specific studies that were focusing on difficulty of breathing or shortness of breath. And what they found in there is finding those B lines with POCUS in these patients had a negative predictive value of 94%. Now, what does that actually mean? So with the negative predictive value, if you are seeing A lines on the ultrasound, indicating a normal lung, there's a 94% chance that that's actually what you're seeing and it's not the congestive heart failure. So this really means that it's a great way to rule it out. If you're not seeing the indication that it is pulmonary edema, it's not going to be that. Now, the study also found that it had a positive predictive value of 77%. So what this is saying is that if you're seeing the B lines on there, which would indicate pulmonary edema and a probable exacerbation of congestive heart failure, 77% of the time, it's actually positive. Now, what we actually take from this, because not many of us are going to be on the rig going, well, the negative predictive value is 94%. No, what we're going to be thinking is, all right, I see B lines on this ultrasound. That probably means we have pulmonary edema and an exacerbation of congestive heart failure. Now, if we have a shortness of breath patient and we're not seeing those B lines, we can pretty safely say this isn't congestive heart failure and should start going down our differential list for something else that can be causing it.
So these are some great studies out there that are really furthering the discussion with point of care ultrasound in the prehospital setting. Recently coming back from NAEMSP, which is the National EMS Physicians Conference, there is still a lot of debate right now about whether or not point of care ultrasound has a place in the pre-hospital setting. As someone who is very pro point of care ultrasound, I really do believe that's the case, but this is something that we should talk about when it comes to these studies. When we talk about this lower predictive value of 77% for these B lines, that number is coming from what the clinicians found. So based on the set of clinicians that did this study, there was a 77% positive predictive value. That's a big difference compared to the negative predictive value, right? Like a normal ultrasound was pretty reassuring for most people. But it comes down to this technical component as well. And this is where the argument currently lies, is can we train paramedics to effectively perform a good lung ultrasound and confidently conclude that there is no pulmonary edema or there is pulmonary edema? This is where that discussion is going to be ongoing. And as there's more studies to demonstrate the effectiveness, that's going to be part of it. But the other side of this is sometimes there's concerns about the fact that if we use point of care ultrasound in the pre-hospital setting, will it slow down patient care? And that's a valid argument because right now we just don't have enough data to verify whether or not that's the case. Since I am a pro point of care ultrasound person, I would like to present a scenario just based on the data that Regan presented. So let's say that Regan got called to a patient's home who was short of breath and had a very complex history, including like COPD, CHF, and maybe some history of pneumothorax in the past. Her having the point of care ultrasound skills in place would allow her to quickly put an ultrasound probe on the patient's chest. This is, of course, assuming that she's done all the appropriate avenues to make sure the patient is stable enough to perform this quick examination. By putting the probe on the patient's chest, she is looking to see whether or not she's seeing any B lines. If there are, we have CHF, and she can start to treat that patient much more quickly and try to get a much faster recovery for that patient. An alternative would be, there are no B lines, but I'm not seeing any lung sliding. This patient might have a pneumothorax, which is why why they're hypoxic. Or it could be, I'm seeing a normal lung exam. I don't see any fluid on the lungs. I see normal lung sliding. This is probably their COPD. And then she can go down the COPD pathway instead of problems sometimes that arise with these very complex patients where you're treating using 3 different pathways because you're not totally sure what's going on. The counter argument could be made from people that don't feel that POCUS has a place in the prehospital setting. You could base this on your clinical exam findings. And I agree. To some extent, this is for physicians and medical students. This is going to be an extension of the physical exam. I really hope it doesn't completely replace the stethoscope because we still need to use our brains. And I expect the same thing of my paramedics and my EMTs. I want them to use their brains. But this is just a nice adjunct. It's a nice discussion to think about where ultrasound could have a role in these types of situations. I've been on my BiPAP soapbox and I've been on my point of care ultrasound soapbox. So I think I'm all out of soapboxes for today. I think we can move on to the protocol itself now.
So we've really ran through a good portion of the protocol just from going through this podcast today. We are going to start, of course, with assessing our patient, getting that history from them, the physical exam, definitely our vitals right away to start kind of figuring out what our clinical picture is. Now, if we're going down that CHF route, that first line that we can do is actually that oxygen therapy to make sure that we correct any hypoxemia. But of course, right after that is coming up with our nitroglycerin. And within our ambulances, to keep it nice and simple, we can stick with that sublingual nitro that we know we all have. We don't need to be fancy with a nitro drip. If we don't have it on our service, that is completely fine. So you can start by doing your nitroglycerin how you normally. So using our nitroglycerin, the 0.4 milligrams sublingual, of course, if our blood pressure is higher than 100 systolic, absolutely be checking the blood pressure before and after every dose. We want to make sure we're not all of a sudden dropping blood pressures in patients who are already having difficulties. From there, we can repeat that nitroglycerin every 3 to 5 minutes, and our maximum is actually 3 doses. However, if we believe that our patient would benefit from more, there's no problem with calling med control, explaining the situation, and getting that approval to continue with some sublingual nitroglycerin. From there, we want to continue assessing our respiratory status, possibly considering doing some non-invasive positive pressure ventilation like that CPAP or BiPAP that we've talked about, and of course getting onto the rig and starting that transport as soon as we can. While we're on the rig, we can definitely give the furosemide, 40 milligrams. While we're en route, it's not something that needs to be started at the scene. We'd rather focus on that nitroglycerin. And then, of course, if the scenario calls for it, and this is more of a cardiogenic shock, we're going to move towards that epinephrine, norepinephrine, or dobutamine, of course, starting with that epi.
And I do see that there's a little blurb in there about RSI in the context of severe distress. I would really, really, really encourage my EMTs and my paramedics, if you're in the context of someone that you suspect is in CHF or a cardiogenic shock picture, obviously RSI we need to do if the patient is absolutely going to lose their airway, but make sure that we've exhausted every single avenue in terms of like non-rebreather. If we've got BiPAP or CPAP, try that. But if push comes to shove and we can't get to the ER before we can intubate, then you've got to make that call. But in the context of CHF, these are very tenuous situations. So I'd really prefer avoiding intubation. Even for me personally, when I'm in the ER, I'm going to avoid intubating these types of patients if at all possible. Trying to get a patient intubated and ventilated on top of dealing with heart failure is a big task. This protocol was actually much shorter than our previous protocols, so that was very quick and simple. Let's move back to the original case here, Regan, and let's discuss what you want to do. 65 years old. She has a history of CHF as well as probably a bunch of other cardiac problems. You know that she's very puffy. She's got a lot of edema in her legs. Blood pressure is 220/90. She's tachycardic. She's got O2 sats of 83%. Clinically, what is your suspicion right now? Like, what do you think is going on with this patient?
Well, my suspicion, of course, is going to be something along the lines of an acute on chronic heart failure. Another thing that can help us determine what's going on is asking the patient if they've experienced something like this before. Our patient might say, this happened last Thanksgiving too, which can help point us in that right direction. But yes, definitely leaning towards heart failure.
Right. And specifically, one of the other terms that's thrown around a lot in the ER is flash pulmonary edema. So this is a patient who suddenly got really short of breath after Thanksgiving. Her pressure's through the roof. She's tachycardic. She's got really bad O2 sats. You know that this is a heart failure picture and you just need to start working down your algorithm to get stuff going. So what do you want to do with this patient, Regan, as you're getting the IV in and you're getting her loaded up?
So I'd want to make sure we have some oxygen on her. With that SpO2 of 83, I'd probably put her with the non-rebreather mask to start. Also can help reduce some anxiety by having that full mask on as opposed to that nasal cannula. And either while I'm doing that or my partner's doing it, I'm reaching for the sublingual nitroglycerin to get that started.
So with the non-rebreather place, we'll say that our O2 stats improved to roughly 86% on 15 liters. So non-rebreather is not really doing a ton for you right now. You do note that when you give her the nitro, her blood pressure does seem to respond a little bit. She's less severely hypertensive. She maybe looks a little bit more comfortable, but she's not a stranger to CHF, and she's reaching out with her hand gesturing for the CPAP mask or the BiPAP mask.
And if that's on our rig, that's what I'm moving to. So we can have that on the patient if they are used to it and comfortable with it, even better. But with starting a CPAP or BiPAP, it's very important to explain what's going to happen to the patient, since that pressure can sometimes be overwhelming to them.
I totally agree. And I would add, in this particular scenario, this is someone who's very familiar with it. And those types of people are going to ask for it every time they come to the ER or an ambulance comes to pick them up. In the case where you have a patient that's not familiar with BiPAP or CPAP, and you've got the time and the patient is stable enough, you can sometimes teach them how to do it. And sometimes I talk about just by taking the mask, holding it over their faces and get used to the idea of the pressure hitting their face, giving it to them, letting them hold the mask, put it on their face so they get an idea of what it feels like. And as they get more comfortable, you can then place the strap over the head and they can probably tolerate it a lot better. So by taking those baby steps, if the patient is stable enough, you might be able to facilitate them getting better faster. I will also add that in my experience with these patients that have flash pulmonary edema, it is really impressive how quickly they look better the minute you get BiPAP and nitro on board. Especially from the ER perspective, when I get a nitroglycerin drip going for these types of scenarios, and you get the BiPAP on them, they go from looking really stressed out and diaphoretic to much more calm and relaxed. Now, they're not out of the woods yet by any means, but that allows us to get IVs in, to do Lasix, and do the other interventions we need to get them turning that corner. So, Regan, you do all those things for this patient, and I will say that her blood pressure starts to go down nicely. I would say it's probably about 160 over 85 or so. Heart rate's still around the hundreds. Her respirators have improved to the mid 20s, and O2 sats with the BiPAP on is probably going to be about 92, 94%, I'll say.
So definitely feeling a lot better about all of those vital signs. And I would also hope at this point we are already en route to the hospital. Because again, we can only do so much in the field, and that transport and early transport is very important for their symptom improvement as well.
It's only a short 10-minute drive, so you have no decompensation or any other problems arise, and you get them there safely. And just like that, we've gotten through CHF. These just get faster and easier all the time.
No, definitely a quicker one, but still a very important one that you're going to see pretty often.
Very common indeed. So definitely get this stuff figured out. Definitely get the hang of it. Definitely get comfortable with this physiology. And just to do like a very brief and simple recap, when it comes to patients that we're worried about CHF, keep in mind that there's a spectrum. There's going to be the patients that are having an acute or chronic heart failure flare. There's going to be the ones that are decompensating. You've got these, what we call the SCAPEs, the sympathetic crashing acute pulmonary edema. So they're starting to burn through their catecholamines because they're trying to keep things going. And then we get into the cardiogenic shock phase, which is the scary phase. We've got medications and some interventions that we can use for the milder cases or the ones that are more stable. So things like nitroglycerin, like we talked about, that we can do sublingual, especially from a rural setting. Drips are out there, but that's going to be more in the context of transferring out of one facility to another. We can give furosemide or Lasix 40 milligrams to help start to facilitate that process. And if push comes to shove and things get very scary and we get into that cardiogenic shock, keep in mind that these are the type of patients that have burned through all their catecholamines. And so what we can do is provide them with additional catecholamines such as epinephrine, norepinephrine, and dobutamine. And remember that with each of these, epinephrine is the best one because it's targeted towards cardiac output, blood pressure, and heart rate. Norepinephrine is going to be more your vasoconstriction, and dobutamine is going to be more so for heart contractility. When it comes to pre-hospital stuff, mainly we're going to be thinking about epinephrine and norepi. But if you're doing a transfer, again, like we talked about, dobutamine would be your next player. We talked about how point-of-care ultrasound could be a great tool in the pre-hospital setting, especially in these undifferentiated shortness of breath, but there's definitely still more room for research there. And then we lastly kind of walk through the protocol, which will be available for you to look at your own convenience. So with that, we will wrap up yet another exciting episode of Medics, Musings, and Mayhem, and I look forward to seeing you all again very soon as we talk about our next key topic.
And there you have it, another podcast completed. I wanted to take this time to apologize for the large gap in between our podcasts. It turns out preparing for a wedding, getting married, going on a honeymoon, and getting yourself reorganized takes a lot longer than I thought it was going to. So I apologize for the large delay in production of this podcast. Again, I would like to extend a personal thank you to my friend Phil Aguet for helping us clean up this podcast as best as we could. Over the next few weeks, we'll be working on some shorter content to get us back on track. Obviously, we would welcome any feedback or suggestions about things to discuss in the future. Our next topic of interest will be related to RSI. But until then, may your mayhem be well controlled, full of teachable opportunities, but also provide you with the opportunity to provide your patients with the best care possible.